Hello, and welcome back to the Thoracic Surgery Clinics podcast. Thoracic Surgery Clinics is a quarterly publication from Elsevier, consisting of review articles centered on a major topic important to thoracic surgeons. My name is Megan Ashdown, managing editor of the series here at Elsevier, and we'll be discussing the November 2025 issue devoted to precision medicine and thoracic surgery. Leading the discussion will be our consulting editor, Dr. Virginia Lytle, Director of Thoracic and Foregut Surgery at the Sutter West Bay Medical Group in San Francisco, California. Joining her will be the guest editors of the issue, Dr. Rian Hassan and Dr. Fatima Wilder, both assistant professors of thoracic surgery at Harvard Medical School in Boston, Massachusetts. Welcome, and over to you, Dr. Lytle.
Thanks for joining, and thanks for being the guest editors of this issue. You both compiled excellent list of topics and invited experts in our field to write about this very progressive and state-of-the-art area. As our guest editors share in your preface that we are expanding the frontiers of thoracic surgery through precision medicine, and we are emphasizing the challenge of all walks of life benefiting. So I'm going to start off with thank you again for guest editing this issue of Thoracic Surgery Clinics. We could have discussed many wonderful contributions from our invited authors, but I have some questions for you about several select topics from the issue. Before we get started with those questions, however, I'd like to ask you a couple of things about you. So, Dr. Hassan, how did you develop an interest in precision medicine, and how do you apply it to your research and practice?
Great. Thank you for having me. So I think, when I think back to what thoracic surgery looked like as a medical student, and that was my first introduction to thoracic surgery, and then thinking about it as during residency and then fellowship. And then now as an attending, I've seen we just get more and more specialized in everything that we do. I think that back when I was in medical school, it wasn't uncommon to see cardiac surgeons doing thoracic surgery. I think there was a little bit of meshing of the fields, especially when you were out in the community. But as things have gotten more and more complex, we have definitely gotten more specialized to the point now it's just not that you do minimally invasive surgery, but we do minimally invasive lung surgery versus minimally invasive esophageal surgery versus, okay, I do chest wall and or I do reconstructions. And so I think that specialization, we've seen that, as the field specializes, what we do for the patient also needs to specialize. And so a 2-centimeter tumor is not the same in every patient. It could be a 2-centimeter tumor in a 56-year-old versus a 2-centimeter tumor in an 85-year-old. It could be solid versus ground glass. It could be peripheral versus central. And so I think when you think of all of this, you're like, wow, we can't treat everything the same way like we did in the past. And so when I think of my research, my biggest focus is on mobile lung cancer screening. I actually partnered with Dr. Wilder to do that in our underserved communities around Boston, really reaching back to my experiences when I was in rural populations in New Hampshire and Vermont. Reaching those patients in Boston is not the same as reaching those patients in New Hampshire. And so you have to, that phrase, meet people where they're at. That's where that precision and that specialization comes in. So we've gone to the basketball tournaments and given a little mini information about lung cancer screening during halftime or at the quarter break. We've gone to churches and given a talk during the announcement section from the pulpit, because that's what's going to reach those populations. And I think that extends out if we, God forbid, find a tumor and we need to treat it. How do we treat it specifically? What mutations are we going to look for depending on the size? What treatment is this patient going to get? Are they going to need something in the neoadjuvant or adjuvant setting? So I think taking that all into consideration, it's just we're getting more specialized. And so our work has to do that in all aspects as well if we really are going to meet these patients where they're at and give them the best care.
Yeah, that's great. And I really appreciate having come from Boston University and that population, and now on the West Coast. But I'm really glad that you guys took over that, because
Yes.
it's a challenge, and it's kind of sad that those people present so late with their diagnoses. You know.
Well, and it shows you you can have the same problem, access issue and transportation, but it can manifest differently. And so in New Hampshire, that means driving through the White Mountains or the backwoods of New Hampshire and it taking 2 to 4 hours to get here. Whereas in Boston, that may mean taking 2 or 3 T trains, then a bus, and then getting to the hospital. So it takes the same amount of time, but the approach has to be specialized to the different populations. So I think just seeing that has really kind of helped us really specify and give each patient what they need.
Yeah, that's great. And Dr. Wilder, I have the same questions for you. How did you develop an interest in precision medicine, and how do you apply it to your research?
So thank you for having us and this opportunity. I think my interest probably started primarily during fellowship. Our attendings, as a fellow, I'm sure all of us did the same thing. We just wanted to be in the operating room. Going to tumor board wasn't really high priority, at least in the early portion of training. But then as you become more senior and start to think, oh, I'm actually going into practice, and attending tumor board and learning about all the studies and realizing, oh my gosh, the field is changing. It's not just they have a tumor, you take it out. You have to really understand that tumor. And the more I learned about the trials, the more I learned about the role that our medical oncology colleagues play in addressing our patients' cancer. That's really kind of what sparked the interest. And then fast forward to when I actually started as faculty, getting to know Dr. Hassan and working on the mobile lung cancer screening efforts. But in addition to that, I got my master's in public health as an attending, actually pretty late in the game. But that was when I started learning about social needs and social determinants of health, and this idea that we really need to design interventions to address patients' needs, but it's important that we don't do that in a silo or do it using, kind of antiquated methods. We really need to talk to the patients and figure out what their needs are. So this idea of designing interventions using a co-design approach and speaking to people one-on-one and understanding what their needs are, and then together designing something to address their needs, to me is kind of a different way of looking at precision medicine, but it's the same idea, saying, what do you actually need and how can we address that? So that's really where it applies to my research.
Well, this is great. You guys, I consider you and some other people in our field like definite advocates for this area, and we need to just get it out there and make sure other healthcare systems and academic systems are applying it, because we know I'm in Northern California, so there's a lot of disparities in San Francisco and the Bay Area. So anyway, keep working on it. That'll be great. Now we'll get into some of the submissions in this clinic's issue. You invited doctors from UC Davis, Angelica Martin, Sidra Bonner, and Chief of Thoracic David Cook to start off with maintaining health equity in precision surgery. This is indeed a challenge. Let's face it, wealthy people can travel, MD Anderson, even though they live in Florida, they can travel globally to get the best care for the cancer. So Dr. Wilder, one of the take-home points in Dr. Cook's contribution is that AI can be used to optimize patient outcomes. But they comment that there is a limitation to AI. Can you explain what the limitations are?
Yeah, I think there were several, but maybe a few that I'll highlight. One of the most important, I think, is our ability to train models that are sensitive to nuances, like specifically racial differences. differences that are ethnically associated, anything, things that go beyond skin color. When you think about patients additionally who are multiracial or multi-ethnic, you can't just look at them and make assumptions about what their needs are, what their experiences have been. And if you have an AI model that only sees a patient externally, that may present a limitation. So it's important that as models are being trained, you have a wide variety of patient populations that are being represented so that the model doesn't have a limited pool to pick from. There's also the issue of standardization across different systems. So essentially at this point, everyone is building AI models, whether it's a small startup company or an academic institution or a nonprofit. Everyone is kind of coming at it from different approaches depending on what their needs are, but there should be some effort, and this is another limitation in that it hasn't really been established how best to establish standards to ensure quality and safety, so that the models that are being built are not ultimately doing harm to the people that are being evaluated by them. And then finally, I think when we think about regulation, and even when we think about the FDA and identifying biases that exist in algorithms that have been created so that, again, back to the standardization issue, but this is a little different in the sense that we have to think about AI models that are already in existence and how are they being evaluated over time so that they're not just created and left out there, but being reevaluated and saying, okay, is this working? Is this not working? How is the population changing? And is our model up to date to reflect that? So I think these are all different limitations that were identified in this chapter.
Right. They also write about surgical innovations and what are their approaches to optimizing equitable access.
Yeah, they give some interesting examples. And I think from the perspective of research that's been done or policy that's been in place to increase equitable access, one example they give is the All of Us study. So it's a government funded study. They're gathering data from a wide array of people. And actually, it's funny because after I had my youngest child a few years ago, I was approached in the hospital to contribute data to the All of Us study. So I find it interesting because as an African-American woman, we are one of the groups whose data is often not represented in larger studies. So this was one example that they provide to say, if we're going to be doing research, we really need to ensure that it is equitable and that it is representative of a wide variety of groups and the data that we're collecting. Then they also highlight the importance of equitable access through insurance. They do reference the Affordable Care Act. I know there have been changes in that arena as of today, but the idea behind it being that insurance companies were no longer being allowed to exclude people with pre-existing conditions. And if you can't do that, then you have insurance coverage, and therefore you can have access to the latest and greatest surgical innovation that you may not otherwise have had access to. So I think it's leveling the field so that everyone is allowed to have access to the newest innovation that's available to them.
That's great. So moving on to another topic, you invited oncology folks from Dana-Farber in UT Southwestern and University of Miami, Narjas Flores, Arthi Sridhar, Lauren Keel, Angela Morabito, Rebecca Coffin, and Coral Alazagasi. Do you know all these?
I know almost all of them. I know Narjas the best because it's funny, we met back on Twitter many, many moons ago before she even gained to the Farber. Yes. And so our paths crossed because of our Mayo connection. And then we just kept in contact and then we ended up at the same place. And here we are working together. So
cool. That's great. You asked them to write about molecular therapy and targeted treatment for cancer, which is obviously a current approach. This past decade, we have seen many advances in lung cancer. In particular, 5-year overall survival rate was stagnant at 20%, and now it's at least 24%, thanks to targeted immunotherapy and lung screening, which still needs to expand given so few smokers or former smokers aren't screened. Dr. Hassan, please share with us the major clinical trials completed in the past few years on the benefits of targeted and immunotherapy. I know it's a huge topic, but you can summarize.
Exactly. I'm going to summarize like the authors did, but I think, one of the things to think about is that it's so interesting, and you actually see this in both lung and esophageal cancer, how everything starts with surgery, and then we start saying, okay, what adjuncts can we add to this to help get us a better response? And when we think about esophageal surgery, it was taking it out. And then we said, maybe we should add some chemo. Then we said, maybe add some chemo and radiation. Now okay, maybe let's go back to more chemo. Let's go to chemo and immunotherapy. So it's, and that's watching that whole journey has been super interesting. I think in lung cancer specifically, really it's about Keynote 671, Checkmate 771, Checkmate 816, and then the Asian trial looking at Pembro, durvalumab, nivolumab, and all of those agents. And really what they saw was that in these stage 2, 3As, and 3B cancers, whereas those patients would likely get preoperative chemotherapy, and then we started adding immunotherapy on the back end. What about adding it on the front end? And we saw a lot of dramatic results with these 4 studies. I think one of the most important things is the regression of the tumors and the frequency of a complete pathologic response, which we weren't seeing before with chemotherapy. It might shrink it down and you might get sterilization of the lymph nodes, but there's likely still going to be some tumor there. Whereas now we're seeing some of these shrink completely, and because we're giving some treatment on the back end, they're staying away, and we're getting less of the recurrence. I think the tricky part is going to be, making sure that the toxicity of these agents doesn't limit these patients getting to surgery. And I think with some of these studies we've seen, that's one of the biggest indicators is either there was a major complication and the patient couldn't get to surgery, or, they got sick, or perhaps in rare cases they died. I think limiting those complications so that we can ensure that these patients still get their resection is going to be the biggest thing. I think the data is so promising. And when we think about these are actual results where we are treating this cancer and then we're helping to keep it away, like we're just throwing so much at it that it's not coming back. And when we think about how it used to be, I just think the field has moved so far. We're seeing the same thing in esophageal cancer with like the Matterhorn trial and everything that's come out with the Keynote trials, 590 and Rationale 306. So really, when I look at these, it stresses 2 things: the importance of pairing with your medical oncologist early and often. And so, hey, got a tumor. Can you take a look at this patient for me? What should we be doing here? And then secondly, talking to the patients and making the thought of consulting with our medical oncology colleagues less scary. I think when people think about chemotherapy, they're like, oh no, and one of the great things about these targeted agents and immunotherapy is like, hey, they're designed to target and just hit, specific parts of your body. They are much easier to tolerate, and you can take them for longer time periods with less effects. So this is an alternative and an adjunct that we can add to this. Alternative being in those older patients, or I should say more mature patients that maybe, have either comorbidities or can't tolerate getting full chemo, but maybe could get immunotherapy. Or on the back end, when you have these tumors that were pretty aggressive and it looks like, hey, we got it all, but it would be nice if there was something that could just do a little cleanup and, really keep this space clean for the next, 12 months or so. I think that just all of the uses that we're having for this are just opening doors beyond what we ever thought was possible. And, it's not just in lung cancer and esophageal cancer. We're seeing that in all cancers. I don't think we'll ever get to a point where we won't need surgery. I think certainly for our radiation colleagues, we're seeing that we don't necessarily, first, we weren't using port anymore. And then, we're not, necessarily using SBRT except for in our patients that have significant comorbidities or have more maturity. But I think there will always be a role for surgery, but the ability of our surgery to actually do what it's supposed to do and keep that tumor away and keep, the patient's tumor free and decrease the amount of recurrence and extend lives. I think we're just seeing more and more advances every day. Seeing that we can use either one agent, having the trials where they use multiple agents in lung cancers where it's the same type of cancer, but it presents in many different forms or many different markers. I mean, I think the things that we're doing with this are just inspiring when I think back to where we were in thoracic surgery in medical school, and then what's to come in this field. And so I think the biggest thing is going to be educating our patients. Like, we have more tools in our toolbox than we ever did before. And I think we were able to do that with screening to say, hey, we found it early. Now it's, hey, we found it early and there's multiple things that we can throw at this tumor to try to make it go away and keep it away.
Yeah, that's excellent points. And just a reminder to the audience that when someone presents with cancer, before you start treatment, got to discuss them at a tumor board, because there's also clinical trials available for early stage cancers now. So Dr. Wilder, please share the role and benefits of neoadjuvant chemoimmunotherapy and which stages are appropriate for this treatment.
Yeah, so I think the authors summarize this nicely in that they highlight three primary roles for neoadjuvant chemoimmunotherapy or benefits in association with it. One would be that neoadjuvant chemoimmuno is able to target the micrometastatic disease before surgery. So it's that kind of that analogy of there's a tumor we can see, but then there's a tumor that you could only see under a microscope, and the chemoimmuno allows you to kind of send almost like a vacuum cleaner to the micrometastatic disease that you're not able to identify and kill it off. The second benefit is to downstage tumors to increase the chances of resectability so that by the time they get to us in the operating room, we're able to not have to do maybe as large of a resection or as extensive or that of a surgery that would lead to greater morbidity for the patient. So that ultimately leads to improved outcomes, hopefully in the perioperative setting. And then immune modulation helps enhance our native immune system's ability to fight against the tumor. So that's kind of giving your immune system the armamentarium, I guess, it needs to really be more effective in doing what it does normally anyway. Generally, with the studies that that Dr. Hassan mentioned, anyone with stages between 2 and 3A should be considered, as you mentioned. You're bringing those patients to tumor board. There are situations where you might consider a 3B disease, but that's definitely somebody who you want to talk about in tumor board. Is it single nodal station? Is it multinodal station? Have they shown a response to prior systemic treatment? But generally that, patients with tumors greater than 4 centimeters, node positive disease, single station, not excessively bulky, nodal burden, those are the patients that you want to consider for neoadjuvant chemoimmuno.
Great. It's so exciting. Dr. Hassan, please educate the listeners to what genetic tests should be routine, because not every facility or hospital or surgeons, physicians do check the next NGS or, and the genomic aberrations. But what genetic tests should be routine for early stage, like stage 1 non-small cell lung cancer biopsies?
Yeah. So I think in this day and age, I mean, PD-L1 is old faithful. We've been looking at that since the beginning of time. EGFR, and I think the setting also in thinking about that, we have, about 20% at least of our patients present with no tobacco history. So especially in those patients, you need to be looking at the different markers. There's PD-L1, there's EGFR, there's ALK, there's mTOR, there's RAS, RET, MET, BRAF. ROS1. And so, first of all, I would encourage everybody, talk with your medical oncologist, go to Tumor Board for the residents and fellows. It's very important where you get to hear about where these come into play, see what panels your institution is offering, and see how to order those panels. What we have done at MGB is we actually had a collaborative where we talked with the pathologist. We also talked with the radiologist. And so when a tumor comes out in pathology, if it's a certain size or it meets certain characteristics, automatically the panel is entered. What was happening is you have these tumors, you get them and say, ooh, we need to refer you to a medical oncologist. The final path comes back, then, ooh, we need to order the molecular testing. And patients are waiting weeks for all of this testing to come back. So really trying to work with your institution to have some sort of algorithm, and this is where AI can come in again, to say, to be helpful to get these tests ordered in a timely fashion so that patients can really get that specialized and precision medicine care from the oncologist that they need and from you as the surgeon too as well. I think, especially as we're veering into the territory, as we're treating tumors earlier and earlier, having this information is helpful not only in that early setting, but really if they recur or if they have more aggressive disease than we thought, having that information readily available is going to be what's necessary and what best helps our patients.
Thanks for that advice. And do you have that on your website?
I believe I can find a place, and I will talk to Dr. Flores, and I'm sure she will be able to point me in the right direction.
Perfect. That'd be great. Okay, moving on to another topic. Dr. Loretta M1Z. I can't pronounce her name correctly.
That was actually good.
Yeah, that was really good. You're not alone in that challenge.
And her team from City of Hope, Danelle Shores, Yi Xiao, Aaron V. Young, and Anjani Kotari contributed an article on contributing precision in precision surgery and integrating SDH, social determinants of health, to surgical care in our world. And they introduced the term socio-precision surgery, which is so appropriate and requisite in our world too. Dr. Wilder, please define this term, socio-precision surgery.
So I have to say, everyone has their thing that they quote unquote geek out about. And this was my thing. I was so excited, as I mentioned earlier when we started our discussion, that, learning about social determinants of health and the impact it has on health outcomes really kind of revolutionized my thinking and has become the thing that I just want to know more about. So as I read this, I was so excited. I was like, I can't wait to use this in all ways possible. But essentially what they are proposing is the idea that we have health equity informed surgery that incorporates assessing a few things, not just tumor biology, not just the clinical data, which we're going to collect anyway, and the demographic information, but in addition, incorporating social and environmental factors that are driving and predicting the outcomes for our patients in each phase of their surgical care. So everything from the preoperative setting to their postoperative and then on to survivorship. So the goal would be to get AI models that can combine the clinical genetic information as well as social data to then personalize surgical interventions with the goal of improving outcomes. So you're taking a patient's address their, do they live in a food desert? Do they live, as Dr. Hassan mentioned earlier, are they going to have to take 3 buses and another train to be able to get to you? In terms of deciding how are you going to set up their post-op appointments? How are you going to set up their chemo? Where are you going to send them for their radiation treatment if they need it, so that they can optimize the care that they're going to get in the post-operative setting and not have the social barriers prevent them from completing care? Because we know that it starts with screening, but it's all the way through. We have to make sure that they can actually complete the treatments that we know work.
Yeah. So this is an exciting topic, and I think you just answered the second question about how we can prevent precision medicine exacerbating healthcare delivery disparities gap. But using AI, you think will be?
Yeah.
Okay.
I think so. I think so. I think using AI from the beginning, making sure, as we mentioned earlier, that it's inclusive of all different groups that we are going to be treating in different settings, making sure that all systems have access to these models. So rural, smaller community hospitals have the same access as larger academic institutions from a funding standpoint, from a, access standpoint in terms of what is available to the hospital. I think of Epic, right? And what levels of Epic is available to different hospitals. And sometimes that's dependent on funding or how much they're able to pay. To me, it's similar with these AI models, that you make sure that all the different hospitals have access to models that are equitable. And then from there, making sure people know how to use them appropriately and how to apply the data that they're gathering from the models.
Yeah, that's great. So continuing on about AI and machine learning, because they are hot topics currently. I've had some surgeons abroad think it's going to fade, but I don't think so. It can only get better. You all invited doctors Alexander Pullman and Zaid Abdel-Sattar from Chicago to write about this topic. They don't think it's going away either. Apparently, at the time of publication last year, there were at least 350 articles in literature on AI and thoracic surgery. I'm sure there's over 1,000 now, but most publications reported about its use in esophageal and lung cancer. Dr. Hassan, please summarize the role of AI and machine learning in lung cancer screening.
Yeah. So I think it's, since AI is all around us, I think it's important to take a step back and think of what is the goal of AI? And really it's to be like a human in all forms, recognize patterns, to learn, to problem solve, make decisions, and understand our language, whether it's spoken, whether it's on paper. And even I think they have AI technology that will pick up signing and, be able to translate that to populations that need it. So, when you think about that, there's many different subsets in AI. I think machine learning is where it really comes into play with lung cancer screening. And that's where it's the ability to group data or form patterns with data sets. And these huge databases, it looks at all of this and says, okay, what are some of the lessons that I learned through this? And so with screening specifically, we're able to look at lung nodules now and say, hey, are they high risk and are they low risk? Which I think has many great implications for the patient. Number one, one of the biggest things that is associated with lung cancer is fear and stigma. The fear of, oh my gosh, this is one of those deadly diseases, and this is on the realm of pancreatic cancer, and you're gone. And, and it's how it was portrayed in the media. I think it was also how we saw it clinically present. It used to be 3, 4 or 5 centimeter tumors, already had nodal disease. And with the advent of screening, we're seeing the 9 millimeter nodules, the ground glass, the adenocarcinoma spectrum lesions. And, this whole new world has kind of opened up to us, in addition to the CTs that you get in the emergency room and all of the other radiologic testing that has improved. And so we're picking these up earlier. So specifically with lung cancer, some of the promising results are a program called SIBL, which I actually sit in on the group with Leisha Sequist here at MGH. And so it has been able to predict risk for a lung nodule for up to 6 years, for a patient, even just on their first scan. So when you think about that, wow, one of the biggest problems with lung cancer screening is that, and we looked at this in New Hampshire and Vermont, we asked patients, hey, what are your thoughts on lung cancer screening? And, they were like, well, I get screened, but if the scan says I'm okay, I'm good. There's no thought about the future of no, this is just like a mammogram every year, like you need to come back and get this done. This is not one and done. I'm glad that it was negative, but we're not done yet. So when you think about that, that can maybe help to address that. And if we know that this is a super low risk nodule, maybe that patient doesn't need to come back year after year, and we can have them come back in 2 years or 3 years, et cetera. So I think that it helps to alleviate fear. Scan anxiety is real. Everybody can talk about patients that come in and say, oh, I was so nervous before I came in here. And, depending on whether the results are good for them and, hey, scan is normal, we didn't see anything, or no evidence of recurrence, that can be great. When it's not, hey, we found something, that can also incite anxiety as well. So if we have this predictor that can say, hey, we see something, but it's extremely low risk, or hey, we see something, it's of high risk, but keep in mind, it still looks like an early stage, cancer because of the size of it and because it doesn't look like there's other things involved. I think that just helping to quench those fears and help patients get over, just the challenges that they face in terms of showing up for screening again and again. I think it has the ability to, move us forward. And we have been slowly moving the needle and getting out of that less than 4% to now less than 15%, of patients. And, have to keep faith in this. I know I was looking at breast cancer screening and, they're at about 72% now, but at their 20-year mark, they were only at about 25%. So, and we're not even 20 years yet. So we're still very behind, but that gave me a little bit more hope to keep hope alive. But I think specifically with AI, not only are we seeing it with screening, but we are seeing it across the spectrum of cancer care. So with those screening, being able to look at that nodule, predict is it high risk or low risk. If you need to come in for a biopsy, using robotic navigation techniques, and those smaller nodules that we didn't really think that we could get to with Varin, or that we couldn't really get to with just looking at the CT scan, we can navigate out there and get to it. I think during the surgery, using robotic techniques, the robotic technology is getting more and more dependent on AI, which is helping to augment the way that we operate. Once that specimen is out, and depending on what type of specimen you're doing, AI technology can help you with segmentectomies and saying, okay, really, what are the borders that I need to take out to make sure that I do a good oncologic resection? And then on the back end, when you think about the pathology and how specimens are processed and looking at those high risk versus low risk features, it's really remarkable how it's just been integrated along the entire treatment spectrum of lung cancer care. But I think it starts at that beginning with screening and really just assessing the risk. Is this high risk? Is this low risk? And helping the patient, understand what the future holds for them in some shape or form.
Yeah, definitely. It's so exciting. I didn't know that about mammography. Thanks.
I was like, okay, I have hope. We're not that far behind, I think the problem is, though, our patient population is so different. A lot of people come in and say, I'm ready for my mammogram, and it's automated at so many hospitals that you come in and get it. And as you're walking out, they say, let's schedule next year, or you can go on your phone and schedule it depending on where you're getting it done. Whereas lung cancer screening, because we have all of the criteria that have to be met, shared decision decision making if it's your first time. There's just, stumbling blocks along the way, and really areas where patients can just fall through the cracks, and you get more and more that fall through the crack at each step with more steps, and then we end up with the numbers that we have. So I think regulating that, I think in the mobile screening work, all of us are trying to have one-stop scanning. So you come, get your shared decision making, your tobacco cessation, we get you, get your insurance, sign you up for insurance. If you don't have it, we're lucky to have Mass Health here in the Massachusetts. Get your scan and then get it read, and figure out what the next steps are. So, yeah.
Yeah. It can only get better.
Mm-hmm.
So, Dr. Wilder, what other areas in general thoracic surgery would AI be helpful in besides esophagus and lung cancer? Do you have any thoughts on that?
I think it's already helpful. This may be off the mark, but when I think about like our airway surgery, our chest wall reconstructive surgery, in terms of models, like actual models that can be developed to say, okay, this patient is presenting with this pathology. How can I use AI to give me new ideas or new ways to approach this issue, especially when I think about complex cases where someone is like a redo, and I've already tried what the textbook says and that's not working, or they're presenting with a complication sooner than I expected. So how can I tailor their care to their specific body habitus? I think of 3D printing, even though I guess that's quote unquote, that's old news now, I guess, 3D printing. But I think AI is almost like the new version of that when it comes to thoracic surgery that's general thoracic outside of the oncology realm, that really can make a big difference and make us think outside of the box in terms of addressing patients' needs.
Yeah, I think you're right. Yeah. Okay, moving on. You guys know Dr. Brandy Scully, ethicist and cardiothoracic surgeon. Yeah. I did a debate with her several years ago. She won. She's an ethicist. Anyway, she wrote about the important topic of the ethics of precision medicine and CT surgery. She co-authored it with Doctors Marielle Gross and Hang Wang from Temple and Johns Hopkins. So we'll start with Dr. Wilder. Again, the authors write about addressing healthcare disparities, and a hot topic like AI and the use of precision medicine. I just want to emphasize how we can minimize increasing the gap between patients with money and insurance and the underserved. You guys have kind of touched on that, but do you have some pointers, either of you?
Yeah, I think, well, first of all, I'll say I do know Dr. Scully because we trained together at Hopkins, and she's now a congenital heart surgeon, and actually Dr. Wong as well at different time points. So they're both amazing. So when I read their chapter and I was thinking about this from an ethical standpoint, one of the things that they focus on, not surprisingly, is more of the cardiac surgery approach and how precision medicine is being used in cardiac surgery. And some of the examples they give are understanding the disease phenotype of a patient specifically. So one example is like looking at gender differences between like valve sizes in a woman versus a man, looking at differences in responses to the way a valve is reconstructed in a woman versus a man, or based on race or ethnicity. And I think while almost the way I extrapolated the conclusions they came to was that we need when we think about how progress is made in terms of insurance, in terms of funding, in terms of closing the gap, is data based. We need to present the data to our policymakers, to our insurance companies, to the heads of these institutions to say, no, we have evidence to say maybe these groups aren't that different. And if you can allow everyone to have access to what they need, then you can help close some of these gaps. Or we've really studied this specific group in depth and we can document that all women tend to run, or all the women we've studied tend to run between X and Y. And if you can provide enough valves or medications or treatments to fit within that, then you will care for the majority of people that are within that category. So I think the emphasis is on having ethical research that is inclusive of a very wide variety of patients, and understanding the biology of those patients, so that when you're developing protocols, when you're developing kind of reimbursement plans with an insurance company and saying, well, I'm not going to cover it for this group of people, you can say, actually, our research shows that this group of people are the ones that really need it the most. So I'm not sure if that really summarizes it, but I think it's kind of going back to the idea that the power is in the data. And by demonstrating that the data supports what we're asking for, you're more likely to have some success in kind of getting the funds you need to close the gaps.
That's great. Do you have anything to add, Dr. Hassan?
Yeah, I was going to say, I think there's 2 points that we have to look at when we're using AI technology. We have to think about, where is it getting its information from? And it's from the patients that it's around. So we have to make sure that the patients that it's seeing are diverse patients from all different walks of life: socioeconomic status, race and ethnicity, gender, maturity and age, and so we have to think of what their history is. What other medical problems do they have? We have to be presenting this technology with a wide range of data, so that when it makes these algorithms and it starts to organize it into these different patterns, it's not doing this on a limited data set. It's actually doing this on a huge data set, which may mean that we need to get more patients into the system for it to actually be able to create sustainable and recognizable patterns. But it's so much more applicable on the back end when we're actually trying to make it work. And so what I mean by that is, in these hospital settings, just like with research, where we want to recruit patients from all walks of life into studies, we need to make sure that patients from all walks of life are getting exposure to this AI technology, so it's not just learning about one population, or take concerted efforts to place this technology in different populations, so that it can say, okay, in this group, these are the trends that I see. In this group, these are the patterns that I see, so that when different patients from these populations come, they actually have some foundation for that. Most of this is going to happen at the major academic centers. So we've got to reach out to our community colleagues and say, hey, we've got these studies, we would love for your patients to be involved, so that we can see patients from all walks of life. I think then at that point, once we have the information and we've hopefully taught it, we've enlisted quality control, that's the scariest part, is, really making sure that we're checking, is what this is learning what it's supposed to be learning? We can learn about all different types of things, but not all that learning is going to be educational or what we need to learn in order to do the job that we're supposed to be doing. And so when we look at, trying to make sure that the quality's there, we have to just be very careful and make sure that some of the stereotypes we already see manifesting in healthcare are not manifesting in our AI technology. I think that second thing that I was talking about is we have to figure out how to scale it down, which I think this is going to be the huge challenge, is because of the environmental strain of AI has already proven itself to be quite massive. Getting AI technology in a financially fiscal and affordable setting, so that we can bring it to some of our community settings and some of our rural settings, or some of our urban settings and lower socioeconomic areas. That is going to be the key to really getting access to all. But in order for it to work in those settings, it has to be trained on people from those settings. So really getting people in and then feeding it back to our community so everybody can benefit is, how we're going to reduce the disparities and the discrepancies in terms of what populations have access to the benefits.
Oh, that's great. So I want to thank you for being experts in this field and, devoting your time to advancing this area. And I want to thank you, all the authors, for their time and contributions too. But hope everyone, our thoracic audience, will enjoy this podcast because you're educating them too, and the trainees. And I think a lot of the trainees are thinking about this space. I don't know how they are at your hospital, but I see a lot of trainees who are thinking about this kind of stuff.
Mm-hmm.
So, yeah.
Mm-hmm. Absolutely.
Reducing healthcare disparities and obviously precision medicine, AI, and all that. But I want to thank you for your time on this podcast and have a good evening.
Thank you so much for having us.
Thank you. Yes, thanks for having us. This was a lot of fun.
Thanks for tuning in to this episode of Thoracic Surgery Clinic's podcast. For an exclusive discount on the issue we discussed today, focusing on precision medicine and thoracic surgery, feel free to visit us.elsevierhealth.com/expert. Thoracic Surgery Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on LinkedIn at Clinics Review Articles and subscribe to the Thoracic Surgery Clinics podcast. Until next time.